Okay, and Amy, I understand that you are the lucky one to tell our audience today what Care Patrol is all about, and then we'll get to meet your team members.
Absolutely, it's my turn. So good afternoon, everyone, and thank you all so much for making the decision to join us today. We have a great program lined up for you. So quickly, I just want to tell you about Care Patrol and our services. Again, I am Amy Fager, and my husband Gary Fager and I are owners of Care Patrol, and we service Central and Southern Delaware, as well as Maryland's Eastern Shore. We've been here for about 6 years, and but Care Patrol, you may not know this, has been around for almost 30 years. So quite a while. The company was started by actually a gentleman who was a social worker, and he saw the need for this service. So he started this company, and now it's grown to 150 offices across the country. So we are very proud of all of our locations. As I said, we've been in business for almost 30 years now. And what we do is we help seniors and their families find safe living options. And that can mean anything from in-home care, home health care, assisted living, memory care, and independent living. We also have many resources that we help our clients with, such as an elder law attorney. Perhaps a realtor is needed. Maybe there's a home that needs to be sold to help pay for care. We have a veterans aid and attendance specialist. We have movers, organizers. We have all sorts of people to help seniors. At Care Patrol, we are a very, and I stress very, we are a very personalized service. We'd like to meet with all of our clients in person. And that was a little hard to do during COVID, but we're back to meeting in person. So what we do, we use a three-pronged process, which is called consult, educate, and advocate. Those are our three tools that we use. And for our consultation, as I said, we'd like to meet in person. And during the consultation, we'd like to find out as much as we can about our client. What are the likes and dislikes? What did they do before they retired? Did they have a career? Were they a homemaker? Just get a little feel for what they might like and not like as far as care goes. Most importantly, we find out what the care needs are. What can they do for themselves, and what do they need a little help with? Also touch on the budget, and also geographical location. As I mentioned, because we have 150 offices, we are able to help people move to another state. Perhaps someone has a son or a daughter in Florida or California. We can help make that transition possible because we have people on the ground doing exactly what we do every day. So we help with that connection. Secondly, well, so after we gather that information from you, we use that to help figure out what would be the best care options for you. And then we talk a little bit about information. We try to educate our clients so that they can make an educated decision about their care. So for instance, we talk about the different types of care and what they really are and what they really mean. A lot of times I get calls and clients say, can you please help me? My mother needs to go into a nursing home. Come, ask a few questions and, mom does not need a nursing home. So there seems to be a disconnect out there. Not everybody knows the differences especially between assisted living and skilled nursing facilities. So we talk about that. And then we also talk about some financial resources that are available that they may not know about. As I mentioned, the aid and attendance, veterans aid and attendance benefit. And also there may be some county subsidies available. Lastly, we advocate for our clients. If assisted living or memory care is the preferred option for care, or a care option that we've suggested, what we do is set up the tours for the communities. We transport our clients to the tour if necessary, or we just meet them there at the facility and we go on the tours with their clients. So we do that to make sure that they're looking for the right things, looking at safety issues. Also, make sure they're asking the right questions and looking for the right things, and making sure that their questions get answered. If not right then, afterwards. And then lastly, we try to make sure that we help the clients afterwards to kind of summarize what they saw, what they liked, what they didn't like, and help them reach a conclusion. Also, Care Patrol has a 5-star rating on Trustpilot. All of you should go out and look at our Trustpilot reviews. They're wonderful. 5 stars for 150 locations is just phenomenal for any business. So we're very proud of that rating, and we all work hard to keep it there.
Great.
Yes.
That's awesome, Amy. Fantastic. And your location services the Delmarva Peninsula, correct?
Correct.
Okay, excellent. I dropped all the contacts into chat, but before we bring on our sponsor and our speaker today, which is Georgette from Tribute at Black Hill, let's get to meet some of your team members. And this is what I always love doing, is going around the little Brady Bunch thing here and ending on this. Oh, my center square just changed, but let me, there we go. Robin Edwards is on the center square here. So let me start with Charles, who's to my right. Charles, tell us a little bit about what location of Care Patrol you're working with.
Good afternoon, everybody. Welcome. My name is Charles Picard, and as Steve said, I'm the Care Patrol franchisee in Prince George's County, and I also work the District of Columbia and Charles County. Have a great time. We look forward to contacting you.
Great. And then I got below Charles, I got Stacy Kerr.
Hey everyone, I'm Stacy Kerr. I cover the Care Patrol office as a clinical care advisor for Baltimore County and Baltimore City area and parts of Hartford County. Look forward to working with you.
And I love this because I'm putting her on the spot. I've got the moving Bonnie Danker there.
Hi, friends and families and professionals. Nice to see you. I'm Bonnie Danker, and I own the Care Patrol franchise in the Howard Montgomery. And we also cover the district with Charles and Robin. So we're so happy to see so many of you here, and we're excited about Dr. Mansbach being with us, and we look forward to working with you soon.
Great. And we've already met Amy, who's on Delmarva. So above Amy, I've got Cindy Evans.
Hi, I'm Cindy Yar Evans. I cover part of Baltimore County and Anne Arundel County. Welcome, everyone.
And then above Cindy, we have the other Bonnie Elliott.
Hi, good afternoon, everyone. Thanks for coming out on this hot summer day. I'm Bonnie Elliott, and me and my mighty team, Billy and Jess, cover Carroll, Frederick, and Washington counties in Maryland, and Loudoun County, Virginia, a little bit south and west, Berryville, Front Royal, Winchester as needed with Robin and Scott. Thanks.
Great. And then in the famous center square this time, we have Robin Edwards.
Good afternoon and welcome everybody. I'm Robin. I cover Northern Virginia, Fairfax, Arlington, part of Prince William County, and also part of DC. Thanks. Welcome.
Great. So now we've met the Care Patrol team. Now let me bring on your sponsor for this month, who's Georgette Lake with the Tribute at Black Hill. And Amy, you teed up Georgette perfectly, because Tribute at Black Lake represents some of those care levels that you were talking about. Georgette, tell everybody a little bit about your community and what you offer. Whoops, and unmute.
Sorry
Yeah.
about that. Hi, thanks Steve and thanks Amy for getting me involved with this. I'm very appreciative. I'm Georgette Lake with Tribute at Black Hill. We are assisted living and memory care in Germantown. We're about a year and a half old, And Bonnie is familiar with our location. She's been there before, and we've been lucky enough to have some residents move in from Care Patrol, and we really thank you for that. And I'm very active in the community. I do a lot of events, and I invite anyone that would love to come in for a tour in person or a virtual tour to contact me. I did put my contact information in the chat box, and I would love to set that up. We are doing a huge event next week on the 22nd of July, and that'll be posted on my LinkedIn page. So if you don't follow me, please do. And it's with the Gaithersburg and Germantown Chamber, the Business After Hours, the first live event, and it'll be July 22nd from 5 to 6:30 at my location at Tribute to Black Hill. Thank you.
Great. And make sure to drop that into chat there, Georgette. That would be
Okay,
great.
I will. Thank you.
Okay. Well, thanks so much for supporting this Care Patrol event, Georgette, and drop in your contact so everybody can check out this brand new community that's in Montgomery County.
Great. Thank you.
And with that, I think we have done all of our housekeeping. And so now I would love to welcome the man of the hour here on, Dr. Mansbach. And thank you, Care Patrol, for securing Dr. Mansbach. I've heard him speak a handful of times, and it's always enlightening. And I understand you've got some late breaking news that you're going to be sharing with this audience. So I'm especially intrigued. But before we dive into your topic and I duck behind the curtain here, Dr. Mansbach, I know you as the founder of the BCAT system, which is a system that is widely used in the elder care world. Some folks in the audience may not be familiar with that system, but before we dive into that, tell us a little bit about your background and what led you up to your where you are currently in your career.
Well, Steve, it's nice to be with all of you. I always enjoy giving these talks. Mostly it's a chance to hear from you, not just you hear from me. I like to answer questions. So I'll even say now, this will be fairly informal. I will present specific content, but do think about questions, put them in the chat, and I think Steve will monitor as we go along. So I've been doing this work for a fairly long time, the work being memory care or neuropsych work. So I come to you as the creator of the BCAT, which is an integrated system of assessing people with cognitive issues, treating them, and doing some mitigation or prevention strategies. Not lots of programs, many communities use BCAT throughout the country, throughout the world. I run something called the BCAT Research Center, which is an international research center, but actually its home is here in Maryland. So it makes it convenient for me, and that's a plus. I'm also the CEO and president of CounterPoint Health Services. So we're in a lot of these communities, including Tribute. So we provide psychiatric, neuropsychological, and memory care to older adults. So we do that in Maryland, we do that in Virginia, and increasingly we have a larger telehealth footprint nationally. So I won't go into background on research and all the things that we do. People can always check that out. I want to give as much time as possible to the content of what we have here. So
excellent. This is great. So folks, I'm ducking behind the curtain here and turning it over to Dr. Mansbach. But as questions come to you, feel free to type them in to Q&A. And Dr. Mansbach, anytime you want to check in, I'll let you know if there's anything that has come through based on what you've shared.
That's great. Okay, everyone. So when we were asked to give this talk and we submitted PowerPoint, that was really quite some time ago, and a lot has happened since then. So today I'm going to be talking with you about psychological burden associated with COVID-19. I will talk about some of the programs that you could leverage BCAT tools, in particular, a little bit about the ENRICH program. But I also want to talk to you about a tool called the M5, which is, I think, the only peer-reviewed, published, validated psychological burden scale or stress scale for measuring, well, really stress associated with COVID-19. I don't mean just for those who have COVID-19, but just living and working in or during a pandemic. And then I'll want to talk about a program called 15 for Me. And Steve, you had referenced late breaking information. So this is the most recent research on how to reduce stress in sort of a reasonable, practical, and inexpensive manner. I'd like to talk about the data regarding that. Now, there are a number of slides, quite a number of slides in this presentation. I'm not going to go over all of them because I do want to save time for talking about M5 in more detail, talking about 15 for Me in more detail. But what I will do is break this talk into 3 segments. We'll talk a little bit about background of COVID-19, not the somatic issues, but some of the psychological ones. It is interesting now, and having begun doing research and talks about COVID-19 all the way back in April of 2020, and to track this over time, some of these issues are evergreen. I mean, they just seem to stay with us and will for quite some time. And I think you'll recognize some of those when I talk about it. I will also introduce a way of thinking about psychological burden associated with COVID-19, and it's really in terms of trauma. And you know a lot about trauma-informed care and that sort of thing. So I think the paradigm will make sense for you. I'll talk about what happens in the body when we are subjected to chronic stress, what it means for psychological expression and even somatic or health expression. But mostly, I'll talk about evidence-based tools that you can
Hi, Sister
use
Caridad. This is Bonnie Janker from Care
to,
Patrol. How are you?
I'll talk about some evidence-based tools that you
I
can
am well,
use
thank
with
you.
your
How you
clients
feeling?
every day. I do think we're having some
Good.
interference, so if you're not on
Glad
mute,
to hear that.
Yeah,
go
I'm
ahead.
gonna-
calling
I'm
because
taking
I-
care of that. I got it. Sorry about
Okay.
that.
So obviously, with this pandemic that we have, we know that it affects almost everyone. In the beginning, we focused so much on older adults and those who take care of them. It's still the most at-risk population for many reasons. The most important one being the associated comorbid conditions that so many people have. It is interesting that as late as December of 2020, and to some extent, even into February of 2021, most of the people who died from COVID-19 were older, and indeed, many of them worked in long-term care settings. That's beginning to distribute a little bit differently now. And geographically in the country, there's rather unique distribution of the lethality risk. So clearly, it's associated with getting vaccines. More population is vaccinated, the lower the death rates are. And I'm not commenting on being pro or minus or negative vaccine. It's just the facts are the facts. Now, I had said that having a metaphor, a way of understanding COVID-19 makes a lot of sense. And the reason why it's important is that we're dealing with a pandemic that's now on month, at least, depending on how you count, let's say 16 or 17. We're going to have it for a while. It will wax and wane. We had predicted in the summer of 2020 that if the uptake of vaccines would be slow, that there would be lots of different variants. And of course, there are, each variant being more virulent than the other one, seemingly. So what it means for us from a psychological standpoint is that we have to think about trauma as a long-term phenomenon. So one way of thinking about it is, well, what happens in war situations? I think you could say we're kind of in a war situation. And many of you are on the front lines, aren't you, for dealing with the pandemic and your clients or your residents or your patients, depending on your background, are certainly on the battlefield. I think trauma makes a lot of sense too, because trauma always involves either an isolated or an ongoing series of events. It's experienced either, typically both, in physical and in emotional terms, psychological terms. And it has an impact, sort of a downward cascade impacts on our cognition, memory, for example, physical health, our social health, and I'll talk a little bit about social isolation in about 10 or 15 minutes. emotional, spiritual well-being. And just so that we're on the same page, I think about trauma in 3 different ways. There's sort of the acute trauma. You're exposed to a single overwhelming event. Maybe that would be contracting COVID-19 or having a loved one die from COVID-19. That would be a singular event in acute trauma. Most people, though, will experience complex trauma, and that's just repeated exposure, in this case, to either a population or a situation where COVID-19 has been prevalent and is still possible. And then vicarious trauma, secondary trauma, sometimes called compassion fatigue. I won't spend much time on that, but that's basically when a person experiences a traumatic situation, not because they're in it as a sort of a primary situation, but more or less a secondary one. They hear about it, they're exposed to the news, or perhaps it's a manager who's not on the front lines, but has staff who are and experiences trauma sort of in that way. For our conversation today, it's mostly complex trauma. And for something to really be traumatic, in psychological terms, it must have long-lasting effects. And this is important because there are events that happen progressively or in the future that are going to activate all these symptoms. They don't clearly go away. So one way of thinking about the progression of trauma is to think about it in terms of sequences or stages. Now, we start with exposure to trauma or a series of traumatic situations, let's say being in nursing homes or senior living, when there's been flare-ups, or actually in the past year and a half when there have been not just flare-ups, but a concentration of COVID-19 and all the safety features that go with that, wearing PPEs, social isolation, residents in their rooms, not having family members there, worries that staff have not only about contracting COVID-19, but bringing it home to their loved ones. The related issues of, gee, if you're taking care of residents, let's say, in senior living, and you're of a certain age and you also have children, you have to take care of them, and what about their school needs and so forth. So this is all familiar to, I think, everyone who's participating in this webinar. But we should also think about the fact that people who have been exposed to traumas prior to the pandemic, either through child abuse or seeing a horrific event, a murder, or being robbed, or things like that, it changes your risk factor. It could even make you even more at risk for trauma related to COVID-19. So there's an exposure or a series of events of exposure. A person experiences intense fear, the negative emotions, anxiety, feelings of helplessness, and it becomes sort of a re-experienced phenomenon over time if it's not treated. So over time, if it's not treated, you could begin to experience health issues that have a long life to them. So you could have neurological changes, diminished capacity to cope with stress. It's almost as if you're degraded in terms of your stress busting kind of coping mechanisms. That's important. I will also point out that one of the things that we see in exposure to trauma is downstream difficulties in memory. There's a fair amount of convincing evidence, for example, that would say that people who have been exposed to trauma and who are re-traumatized are more at risk for developing memory problems earlier and in a more severe way than those who are not. So it's kind of interesting when we think about illnesses like Alzheimer's disease. We don't have a lot of time to go into that literature, but happy to answer any questions about it. And then over time, increased risk for PTSD, post-traumatic stress disorder, which I think actually is the psychological sort of parallel to COVID-19, very much so. Increased depression, anxiety, and insomnia. And I'm just going to say that we think about anxiety and depression in particular as the psychological sort of twins of trauma and PTSD. But something is really unique with COVID-19, and one of the symptoms is that there is a higher prevalence of sleep disturbance in COVID-19 than in most other traumatic situations. It's sort of a striking thing to study. So when people report having difficulty sleeping and they're otherwise doing fine, you might wonder if that is not symptomatic in some ways to the pandemic. And of course, over time, over decades, certainly over many years, you could have life-altering illnesses like dementia, hypertension, COPD, diabetes, and the risk for substance abuse is certainly there as well. These stressors can be thought of as kind of existing in 4 different buckets: sort of psychological symptoms, social stressors, occupational ones, physical ones, and so forth. I'll briefly talk about them just so that you can say, yes, I recognize that, and be able to recognize it as you work with your clients and with older adults. Psychological stressors, well, witnessing increased suffering. Usually if you're in healthcare, you're quite sensitive to suffering. It's presumably one reason why you're in healthcare is to limit and reduce suffering. So it represents a psychological stressor in and of itself, fear of being infected, but mostly the anxiety or guilt about potentially infecting other people, family members, and friends. Social stressors, isolation being the most important one. I will talk a little bit about what happens with social isolation. It's interesting because now that families are more likely to be able to visit their loved ones in senior living and nursing homes, what are they going to find? Well, what they're going to find after social isolation is that for those who have cognitive decline, there will be more instances of accelerated cognitive decline than would be normal without the pandemic. There's a whole reason for that hopefully we have time to get into. They're in real time, wearing masks is still sort of an interesting thing because it's becoming fairly normal, certainly in long-term care settings. But if you are a resident with cognitive issues, you already have barriers, sort of stages of isolation or separation from those around you. That you're normally cognitive. Now you're adding sort of a material one, a mask. You have to wonder if people with moderate to severe stage dementia, what they make of wearing masks, people wearing masks. Not to mention, we have a population with a 15 to 18% hearing loss situation and with visual impairment. So you can't read lips, can't read facial gestures, makes people feel more isolated and could make people with dementia feel more confused. When that happens, you have more of those BPSDs, right? The psychological, behavioral and psychological symptoms of dementia, like physical aggression, as one example. And stigma is also a social stressor. The occupational ones, we've done a lot of work in this, published a lot in the last year on what is it really like for people who are working in older adult situations. Talk about that when we talk about the M5, but certainly there's a lot of stress in working in these residential environments. In June of 2020, we did a panel, and one of the questions we were asked was, well, what impact will this have on hiring? You all know that retaining staff now in long-term care settings is particularly difficult. It's always been difficult, but it's even more so now. And what we had said is, we're going to lose staff in the teeth, sort of the high water mark of the pandemic. But you know what? Once we emerge from the pandemic, we're going to lose even more. And there are a lot of people say, well, wouldn't we lose less because it's less stressful? And the answer is, actually, when people come up for air, they find that they're really exhausted and they don't always want to continue this work. And if you look at the epidemiology right now, is that in March and April and May, there were more people who left long-term care settings, talking about staff, than there were in June, July, and August of 2020. So it's kind of interesting in that way. Then there are physical stressors, of course, and some of those are just dealing with wearing PPEs and being more dehydrated. That's a potential consequence. A hypervigilance of infection control. I talked about sleep disturbances, and all those things really add up to exhaustion. I'm using the word fatigue, but sort of being benign about it. I think it's more than fatigue. So what are the impact on mental health for all this? Well, studies started rolling in as early as May of 2020. One of the earlier ones was the Kaiser Foundation one. They found that 45% of adults in the United States that were polled, it's a fairly large sample, said that they were more worried or stressed over the virus, and that it really negatively impacted them. But healthcare providers, by the way, they had higher rates. So we knew in the research that we were beginning to publish that healthcare providers who were on the front lines battling this pandemic, that they would have among the highest stress rates. And I'm going to talk about that in sort of in a moment. Before I leave the model or the paradigm of PTSD as a way of understanding the psychological issues of COVID-19, if I take the stages of PTSD that could be applied to any situation, let's say to a vet who's returning from Iraq or Afghanistan, you would have these typical steps or stages underway. So there would be the traumatic stressor, right? The exposure to the event. The person would experience the psychological associations to that, like anxiety or fear or feeling of helplessness. They would naturally try to avoid situations that would trigger those things as much as possible, not always with success, because you can't always control the environment around you. They would feel some negativity, have some negative thoughts. As you know, if your thinking is negative, your emotions are going to be negative too. Your mood functioning will plummet. There'll be what are called alterations in arousal. You might see that as irritability or difficulty concentrating. If the duration of all this, by the way, is for a month, psych people like me would say that that's part of the symptom, part of the symptom of diagnosing PTSD. And then you would have some functional significance. And for us, if you're working in healthcare, that really is having difficulty doing the job, frankly, staying on the job. So this is where end of chain, where you have problems with staff turnovers, problems with retention. So if you look at this model, fits perfectly with COVID-19. Now, I talked about depression and anxiety. Some of you would be aware of what all this really means. So I'm just going to be brief about it. This is not a webinar and teaching you, how do you diagnose major depression or generalized anxiety disorder, but you are working with people every day who may exhibit some of these symptoms. So very quickly, a snapshot of depression from a clinical standpoint. Basically, you have to have 5 or more symptoms in a 2-week period. You have to have either depressed mood, a person clearly has a subjective sense of feeling depressed, or you have to have what's called anhedonia, a loss of interest in activities. For depression associated with COVID-19, it's not depressed mood that's so important, it's losing activities, losing interest in activities you used to like. So this would be somebody who, let's say, enjoyed doing crossword puzzles and now just doesn't really find it very much fun. Someone who enjoyed reading, now they don't anymore. Someone who enjoyed something like Mempics, a way of increasing meaningful engagement, and now they're not as interested anymore. So it's anhedonia more than depression itself that's most important, but you have to have one of those. But you also have to have a change in weight or appetite, a problem with sleep. That's a common one, right? As I said before, sort of a slowness in movement. Sometimes people are more agitated, but you're going to see slowness in movement the most. Fatigue. Some people feel like their self-worth is just low now. They used to feel more vibrant, better about themselves. Now they don't. Difficulty concentrating, or a passive death wish, or suicidal ideation. The difference being suicidal ideation are thoughts of trying to harm yourself. Passive death wish would be something like, it would be fine if I don't wake up in the morning. There's not that kind of ambition to it in some way. So you have to have 5 of those, but one of them must be either a subjective sense of depression or that anhedonia that I had mentioned. So this is really common with psychological burden associated with COVID-19. But there's also the other issue, which is anxiety. And so we think about it mostly as generalized anxiety disorder. And if you really think about it, it's being worried about something. It could be about COVID-19. It could be about finances. It could be about childcare. Like, how can I go to work and take care of my kid? How can I go to work and deal with my child's education? But it's hard to keep it in balance. It's almost as if you can't control it anymore. So this is a sort of a defining feature of GAD, or generalized anxiety disorder. And like with depression, you can have these other sort of associated symptoms: restlessness, being fatigued, problems with memory, sleep problems, things of that sort. So my point here is that if a person emerges with depressive symptoms or anxiety symptoms, then maybe they really are in the grip of psychological burden associated with COVID-19. And what we know about this is just passively waiting for people to get better will not really result in people getting better. You need to be very active about it, which is why programs like 15 for Me, which I'll talk about, are really important, because anyone can do that and get better. Same thing with a program called ENRICH, which I'll talk about. Anyone can do that as well. So before I talk about one of the very specific issues with psychological burden and COVID-19, that's social isolation, its impact when it was really in place, and now its enduring impact. I'm going to ask Steve if you can take a kind of a moment, take a breath, and see if there are any specific questions that anyone would like me to answer about what I've talked about so far.
This is great. Great overview, Dr. Mansbach, and nothing coming in just yet. So you can, oh, let's see. Mary just raised her hand. Mary, sometimes people raise their hand by mistake.
I would like to speak.
Oh, great.
I have a question. My husband is just borderline, early dementia stage. And we are selling a house in Florida and living in Minnesota. We've had two houses for about 13 years, but now just the thought of getting rid of everything that he's had in Florida for 46 years is causing anxiety. I have asked my daughter to come and help distract him when we're there. We only have 2 weeks to empty out the house. What can I do? He doesn't want me to talk about it because he doesn't want to think about it. What can I do to help him during that process?
So this is a very good question, and it deserves and requires a good answer that's probably outside of the scope of what we're talking about now. So Mary, is it Mary? Is that?
Yes, thank you.
What I would say to you is that perhaps even after this talk, I'd be happy to answer your question with a little bit more finesse and a little bit more detail, because otherwise I'm going to be asking you questions before I can answer it, and that'll take the rest of our time. But I do appreciate, it. The one takeaway for everyone, though, related to Mary's question, is that the risk of anxiety and depression, which is high for anyone at any cognitive status, it's actually higher for people who have mild cognitive impairment, that sort of pre-dementia stage, MCI, and those who have mild stage dementia. And so it's just one of those things that you should sort of tuck in the back of your mind, because people are going to be more at risk for depression and anxiety. And the prevalence of anxiety over depression with COVID-19 is clear. So both happen, but anxiety even more. Okay, so I'm going to talk about social isolation, social distancing. I mean, clearly we've needed to protect people, and in order to protect people, we are introducing social distancing. The problem is that social distancing kills people. I'm not being flip, it actually has a lethality association with it. It doesn't kill everyone, of course, but it can make people sick. And those who are at risk can actually, more people have died from social isolation than they have from COVID-19. So I'll say that again. I've said this before. It's been oft quoted and sometimes challenged, but it is the case that we kill more people with distancing them from us than from COVID-19. but distancing is necessary. So how do you deal with that? If you're going to distance people, you have to, at the same time, introduce special efforts to make connections. So programs like Mempics and things like that are going to be really, really important. And the issues are simply that we are social beings. We require a certain amount of social engagement. Not all the same. We're not all created the same in this way, but meaningful engagement, which is really being with people so that we have a sense of belonging and identity, so that old memories are activated, where we're an active participant, is really important. It's important for people across the cognitive continuum, whether you have dementia or MCI or normal cognition, but it's especially important for people who have dementia, because if you don't have dementia, you have the ability to initiate activities to, let's say, get engagement. You can pick up the phone, you can FaceTime someone, you can Skype, you can do all those things. But if you have dementia, you likely have executive skills that are degraded. So you don't have the ability to do it for yourself. You have to require other people to do it for you. So if everyone's socially distant from you, you can see why you would be more at risk. So that's really important. Okay, I want to talk a little bit about the relationship between stress or trauma and what it means psychologically and physically. And so I'm gonna pretend like this is a neurophysiology course, and I'm gonna do it and make it ridiculously simple and easy, so that we all really are on the same page with this. And so what I'll say is that we've got these wonderful stress hormones in our body. They really help us stay alive. And in a short-term basis, they're great. You've heard of the fight or flight response. It's sort of like, picture this, you're walking down the street, it's dark, this creepy feeling that someone might be behind you. So what happens? That cortisol gets released in your body and you have this fight or flight response. So your heart starts pumping more, your muscles start to tense. You basically do what you need to do to protect yourself or to flee. And that's great. And that's cortisol. And that's wonderful. The problem is that if it happens not just as you're walking down the street at night, but it happens day in and day out, then cortisol begins to do negative things. It begins to weaken your immune system. You've heard this before. People get colds or flus or rhinoviruses, things like that, when they're really stressed. And there's a physiological reason for that, and that is cortisol, which is released all the time when you're stressed, begins to weaken your immune system. It can cause over time heart disease. It elevates blood pressure, can actually create or contribute to type 2 diabetes, great digestive issues. Interesting that up to a couple of months ago, and even now, getting antacids and things like that's been harder to do. And so if you look at the sales data, it's sort of interesting phenomenon for PPIs, H2 blockers like Pepsid-AC and so forth, Tums, off the charts. We've never sold more of them. Why is that? It's a response to stress, some nerve issues, and of course, anxiety, depression, headaches, back pains, things like that. So if you have sustained stress, and I'm going to say this now, it may not make sense to you, but it will in about 3 minutes, an M5 score of, let's say 5 or higher for 3 months or longer, you begin to break down a little bit. So you need to do some things to make sure that you're doing better. Whether we're talking about you, participants in this webinar, people you know, healthcare workers, residents, family, we're all the same in that way. Another way of thinking about cortisol and stress is simply this. After a while, cortisol stops being effective. It's great for like taking care of inflammatory responses in a short-term basis, but not in a long-term one. There's a technical term, I won't spend a lot of time on it, called allostatic overload. All it means is that over time, your body wears out, and there are different stages to it. Again, we don't have a lot of time to it, but so social distancing creates stress. If we don't do anything about it, either virtually or in some other way, people are going to get sick. So there's a lot of data on how loneliness or social isolation increases depression, hospitalizations, anxiety, blood pressure, reduced sleep. All the things that you would imagine are basically there. It also can produce foggy thinking, sort of a brain fog in some ways. And we see this, and we've already been able to measure this. So it's not permanent, but people really worry. So picture this. You're involved in healthcare, you're working with families, you're working with older adults, you work with older adults who have cognitive issues, and you find that you're having some memory issues and you're freaking out, aren't you? You're just like, well, this is one thing for my clients, it's another thing for me. Well, you just need to calm yourself, because one of the more common symptoms, psychological symptoms dealing with COVID-19 is problems with concentration, memory, word retrieval. Kind of interesting. So mood behavior, increase in depression, anxiety, that's why we talked about depression and GAD, elevated M5 scores, which I'll talk about in a moment, increases in PTSDs. Okay, so those are those nasty behaviors that are associated with dementia. So what do we do about all this? Well, the first thing I'm going to say is we need to screen ourselves, people we work with, and so forth. We've done a lot of work on the M5, which I'm going to show you in a moment. The M5 is free. It's a way of measuring psychological burden in general, but also specifically for COVID-19. So you can use it for anything. It takes 1 minute to do. You can do it online. As I said, there's no cost associated with it, but it will tell you, based on your M5 score, if you should have like a formal assessment. I say you, but it could be anyone. Anyone could be the you. All right, so it's been vetted in the COVID-19 population. For those of you who know BCAT test system, and there's 6 different tests, and one of them is a mood scale called the BADS, the Brief Anxiety and Depression Scale. You're a care manager, or you're placing people, or you want to know if a person likely has depression or anxiety, you should learn how to do the BADS. But you can start with the M5, because it will tell you if a BAD should be administered by you or someone else. That would be really important. By the way, if you want to find it, just go to enrichvisits.com, look in the banner at the top and click on M5, and you can get it and read about it. Published, really good science behind it. And this is actually what it looks like. So we look at anhedonia, that first item, right? Losing pleasure. We look at excessive worry. For at least 2 consecutive days, have you felt depressed, hopeless, or down? Are you feeling nervous, anxious, wound up much of the time? Are you experiencing fatigue, headaches, stomach upset, or memory problems? Now listen, the M5 started with many, many, many items. We needed to make sure it could be done within a minute, because otherwise people couldn't do it as a screening tool. So it took a lot of science. These are the 5 indicators. What you're really looking for are scores of 3 or higher. So what that really means is that if you score between 3 and 5, 3, 4, and 5, you're at mild to moderate risk for down the road getting depressed or anxious if you don't do anything about it. I mean, depressed like major depression, anxious like generalized anxiety disorder. So we know that 3 months with scores at least at 5 put people at great risk for generalized anxiety disorder and depression. Okay, so we also know that the M5 studies have been done with residents who are mostly 70 and older, with healthcare providers across the country in almost every medical discipline, primary care. So these are providers, psych providers, all kinds of providers, including rehab therapists, including managers in senior living. I mean, we've basically captured all of it. And if you want that information, we can make it available for you, and it can be widely distributed. It is already pretty widely distributed. By the way, in February of 2021, the average M5 score across the country in all these groups, but for right now, I'll just focus on healthcare providers. You know what it was? It was a 5. That's pretty high. So 3 to 5 is mild to moderate. 5 to 7 is moderate. Above that, so 8, 9, and 10, that's really high. Okay, so what do you do about it? It's one thing to be able to accurately measure it. The important thing is to say, well, what do you do about it? Well, You can be in therapy, you can do counseling, you can take medications, all those things are fine. But you can also do one of two other things. You could do a program called 15 for Me, or you can do the ENRICH program, which you can find on that same website, www.enrichvisits.com. Most of those things are free, easily available for people. And it's practicing brain healthy behavior that not only improves memory and cognition, but improves mood status. It lowers psychological burden scores or lowers M5 scores. I think the best thing you can do, though, is the 15 for Me program. And that's interesting because all it is you devote 15 minutes a day, 5 days a week. You can do it all at one time or across the day. Best to do it all at one time. So you choose either a cognitive session, and we give you actually the cognitive sessions, the working memory exercises, all evidence-based, strong science behind them, or a cardio session, and we give you the cardio sessions as well. So you do cardio or cognitive for 10 to 12 minutes, that's it. After that, you do centered breathing, which we teach you how to do for your last 3 to 5 minutes. And so we have very good science on if you do that for even 4 weeks, what happens. So I'm going to share data that was analyzed last night and this morning. So we just fit this in here 2 hours ago for you. And so this is a study. This particular one that I'm going to share with you. These are healthcare workers across the spectrum. So these would be GNAs, CNAs, nurses, people in housekeeping, maintenance. I mean, all aspects, all departments, in different senior living centers across the country. So in one of the questions, all participants were asked how they would rate the program, the 15 for Me program. So their employers basically gave them up to 15 minutes a day, five times a week per month. See what the results were. So overall, 73% had a very positive response to the program. 18% was neither positive nor negative, 9% was negative, but negative was explained by the fact that they didn't have 15 minutes to actually do the program. So it was stressful because they thought, how am I going to fit 15 minutes in, even though their employers gave them the 15 minutes. It turns out that you can get benefits from this program even if you do it for 10 minutes or 5 minutes, but we didn't have them do that. For this study, they had to do the full 15 minutes. People at the management or managers level, 80% positive, 20% neither positive nor negative, but 0% negative. So interesting. Non-managers, so this would be, let's say, line staff, 67% positive, 17% neither, 17 was negative, and it was negative for the same reason. They felt like they didn't have enough time to work on it. Had we said to them, you can do it for 5 minutes or 10 minutes, those scores would have been much different. Now, in terms of the programs, remember it's cardio or cognitive, and then you do breathing after each one. We asked people to choose which they liked best. Turns out that breathing and meditation was the #1 choice if you look at the entire sample. If you break the sample into two, into managers and non-managers, the managers thought that breathing and meditation was the best, followed by cardio, followed by cognitive. The non-managers, though, they thought the cognitive exercises, their working memory exercises, were the best at relieving or reducing stress. So breathing and meditation was second, and then cardio was last. And then finally, we asked them to compare their stress levels before the program and after the program in 2 ways. In general, right, their stress in general, and then their stress associated with their work or with their work environment. So what they reported overall, if you look at all the people and you averaged their improvement, stress levels were reduced by 50%. That's quite a bit for general, right? For general stress, and down 27% for stress associated with the job. And these centers, these folks all worked in healthcare centers. healthcare is among the highest rates, highest M5 rates, highest psychological burden rates. Kind of striking in that way. Now, there's a lot of other data, and there are a lot of things that I could go over in this program, including the ENRICH program and all that. But we're getting near the end of our time. So I'm going to actually stop it here and ask if people have any specific questions. And before I do, if you go to the enrichvisits.com website, you can find a tab that says 15 for me. You click on it now, it's not going to say much because we haven't put all this data in, more about the program. But if you check back in 2 or 3 weeks, you're going to find that all the information that you might be interested in is actually there. So Steve, I'm going to stop here and I'm going to stop sharing my screen for a moment and take any questions that people might have.
Great. Okay. Now, some of these may or may not be directly related to your talk, and just feel free. Kristen has been doing some good posts, and I know that you can follow up. But let's see. Barbara says, would 15 for Me program be good for a caregiver at home, at a caregivers at home setting, caring for a super senior with dementia and Alzheimer's?
Yeah, so it would be exactly positioned for someone like that. So, and you could do it at any time. Like you don't necessarily have to do it if you're taking care of an older adult while you're with them. You can do it whenever you really want to, but absolutely. Those are among the group. See, we started all this by asking people what they needed. When we created the M5 even, it was because people asked us to create it. 15 for Me, people asked, they said, okay, so burden is high. What are we going to do about it? Can you create an evidence-based program that's brief, that has good science that people can do? And so, and there's no education effect. So you don't have to, you know, be a nurse, a doctor, or whatever. Anyone can do this program.
Okay, great. Okay, this is a question, or let's see. Barbara has a follow-up with that. She says, what types of cognitive activities would you recommend and how to find these online?
So we're just going to recommend one, and we're going to be bullish about that. And it would be the Working Memory Exercise Book Home Edition, because it's the only one that has really strong science, objective empirical evidence. And you can find that actually, if you're interested in learning more about it, go to the ENRICH Visits website and go to the bookstore, and you can read about it there. It's a book, by the way, that's used, gosh, it's used in rehab throughout the country. It's used in a lot of different settings, but they're very specific working memory exercises. So you got to go with the science.
Okay, great. Let's see. Okay, I'll do my best here with this one. Extended family friend says her sister asked the same question over and over. Her doctor says cholesterol medication is the cause. Is there a way for the family to learn whether this is early onset dementia, COVID stress, or anxiety, and how to give care? Her doctors are not helpful since she is older, and also her husband died recently, and they say she may be grieving. Sustained stress is interesting and complicated. What and how to get help? Wow, what a great question.
Right, so there's a lot to unpack there, but just to get you started and to do some things that are free, and just I would take something called My Mem Check. It's a free cognitive assessment. You can get that also on enrichvisits.com. It gives you a report. It will tell you whether or not the person should have an actual cognitive assessment. And you can do that if the report says, oh yes, there's an issue here. You can do a virtual BCAT test if you want, or you can go to a BCAT provider who could do that. At the same time, do the M5. See, so start with, is there a cognitive problem now? Is there a mood problem? Before you get to the question, what's causing it? Let's first just document that you have it.
Great. And then this one says allostatic overload, how to spell, what to do, how to manage.
Yeah, so allostatic is all we're really dealing with here is we are living in a time of sustained stress. Think about this last year, COVID-19, a fractious election, uneven economic disparity. It's been a tough time, basically. So I think we're all stressed out. So what we have to do is we have to figure out ways of recovering and not just say, oh, it'll all pass. We have to be active about it. So sure, you can do 15 for me. That's a great idea. But you know what? Practice the other enrich, modifying behavior that you can find on that website. And take the enrich calculator. It's free. It just tells you how you're doing in terms of those kinds of activities. You got to get your life back in some ways, and that requires a very active, position.
Great. Well, I'm looking at the clock and I know you've got another appointment to go to, Dr. Mansbach. I really appreciate your time on behalf of Care Patrol, who lined up you as a speaker today. This has been really interesting, thought-provoking, and resourceful. And your team member has been posting all these links in chat, which I will make sure that gets out and gets shared with everybody who has been attending this.
Well, Steve, it's great to be here. Thank you for having us, and hopefully we can share more information. So check back on 15 for me when we have more to share with you. And it's great to be able to, you guys are the first to get this information. So when you see it out there now, you can say, well, we heard it first, several weeks ago. So that's good.
Love it. Thanks, Amy, for putting this together. And also a big thanks to Tribute at Black Hill for their support and sponsorship of the discussion.
Bye, everyone.
All right, folks.
Thank you very much.
Thank you.
Okay.
Very helpful.
Thanks all. All right, we'll see you next month. I'm excited to hear the next Care Patrol presentation.